Welcome, everyone. I want to welcome you to the first in a series of 3 webinars hosted by the MS Society of Canada, featuring specialists sharing information on MS and COVID-19. Thank you so much for joining us today. Thank you for your time being here. My name is Benjamin Davis. I'm broadcasting from my basement here in my Halifax home. My children could possibly come in at any moment, but I'm happy to be here moderating and very excited for this particular series to begin. My role is I'm the Senior Vice President of Mission for the MS Society of Canada. And I'm very excited about our guests and about the time that we're going to spend together today for the next almost an hour. A few housekeeping notes. The webinar is being recorded for future viewing. No participant names or identifying information is being displayed. If you have a question during the presentations, please type into the chat box on your screen. Questions in both languages will be sent to myself. We will try to get to as many questions as possible, but please note that responses to some common questions regarding MS and COVID-19 will be made available in the near future on our website. Please also note that questions pertaining to specific personal situations cannot typically be adequately answered in this venue, so of course we recommend contacting your MS healthcare professional. This is an unprecedented time. The MS Society of Canada is closely monitoring information on COVID-19 as released by the Public Health Agency of Canada and other health authorities. The health of the MS community is our priority as we manage through concerns related to COVID-19. We at the MS Society of Canada want to ensure you are able to care for your health with the best possible and up-to-date information. To that end, the MS Society of Canada's website has a dedicated COVID-19 page that I highly recommend you visit for regularly updated information. I would now like to welcome and introduce today's specialists, Dr. Ashlesha Sonpar and Dr. Katayoun Alikhani. Dr. Sonpar will start us off. Dr. Ashlesha Sonpar comes to us from the Division of Infectious Diseases at Grey Nuns and University of Alberta Hospitals. She is an infectious diseases specialist at the University of Alberta. She is a clinical lecturer and has a special interest in secondarily immunosuppressed patients, such as patients on biologic medication. Thank you for joining us today, and over to you, Dr. Sonpar.
Okay, thank you for that very kind introduction. I'm just going to start sharing my presentation with you. Okay. All right, so if everyone can see this, I'll begin. So my name is Ash Sonpar, and as Dr. Davis mentioned, I'm from Edmonton, Alberta, and I'm just going to give you a brief overview of COVID-19 and MS, and then I'll answer a few of the registrants' questions that were sent to us last night. So first, just a little bit about the virus. So the virus is called SARS-CoV-2, and the disease is called COVID-19. And this virus is similar to SARS-CoV, which caused an outbreak in 2002-2003. And those of you in Ontario might remember SARS-CoV-1, which did have an outbreak in Toronto. And so SARS-CoV-2, what does that actually mean? So the SARS stands for Severe Acute Respiratory Syndrome Associated Coronavirus 2. So that's what the virus is called. And the outbreak was first reported in Wuhan, China in December 2019. It has now spread to 213 countries and territories. And I think this morning we're up to more than 2 million cases. But these are the numbers as of April 12th from the World Health Organization. And these are the numbers in Canada as of yesterday. So in Canada, we have 27,000, just above 27,000 cases. And you can see the distribution of the cases in the different provinces and territories on the map below. In terms of symptoms, So the most common symptoms that were reported in the literature were cough, fever, and kind of malaise or just fatigue or tiredness. There are many other symptoms that have been reported, including runny nose, chills, muscle aches and pains, headaches, shortness of breath, chest pain, nausea, vomiting, diarrhea, conjunctivitis, sore throat, and other newer symptoms that have been reported since these symptoms were published include things like loss of smell and taste, confusion, loss of balance, and then sometimes seizures or even strokes. The majority of patients will have a mild disease course. That's about 80% of patients will actually have mild disease. And the number is about 16% will have more moderate to severe disease requiring hospitalization, and about 4% of people will be critically ill. The percentage of people who die from COVID-19 vary according to the country that you look at, but the current estimates range between 1 and 12%. And I think in Canada, we're sitting around 3% at the moment. I just wanted to point out, these are from the Public Health Agency of Canada. There's some provincial resources because each province and territory has some slightly different guidance. And so if you wanted to find the provincial resources, they're available on the Public Health Agency of Canada's website, and I'll point you to the local guidance for you. There's also a self-assessment tool that I wanted to point out, which is also available through the Public Health Agency of Canada, where you can take, if you are having symptoms, you can take the self-assessment tool and it would direct you to the best resource for you in your location. So moving on to a little kind of risk factors for severe disease. We do know about some risk factors, including older age, males, and people with comorbidities, specifically comorbidities including heart disease, diabetes, hypertension, and things like that. So what about immunosuppressed patients or immunosuppressed persons, such as persons on biologic medications? So the bottom line are these two things, really. So not much is known yet, and we have conflicting theories. So there are data on a few immunosuppressed patients that have been reported. There was one report in patients with cancer that suggested that they had increased mortality. And there's several reports in patients with organ transplants, so people with kidney transplants, liver transplants, lung and heart transplants, and some of them recovered. The problem with all of these case reports or this limited data is that a lot of these patients were also older, and they also had underlying heart or lung disease. And so it's not just their immunosuppression that might be putting them at high risk. There's also conflicting theories. So there is a suggestion that patients, of course, will be at increased risk because of their immune suppression, as is the case with other respiratory viruses, such as influenza or norovirus, norwalk, or adenovirus. Immunosuppression in general also increases the risk of respiratory disease and infection in general. And this can range from small to large increases depending on the type of immunosuppression. On the other hand, previously with other coronavirus, such as the SARS-1 or MERS, it seems like it hasn't caused increased disease in immunosuppressed patients. And it seems like the critical illness in COVID-19 or the worsening in the second week that prompts the hospitalization is actually more caused by the inflammatory response of the immune system. So possibly, if your immune system was suppressed, you might not have that strong inflammatory response, leading to the lung damage and to hospitalization. So those are kind of what we're working with. So we don't know a lot yet, but then there are these theories out there, and we're hoping to have more information as time goes on. So what does that mean in terms of your suppressive treatment or in your immunosuppressive treatment right now? Should you discontinue it? What should you do with it? So the current guidance is if you're feeling well and your therapy is working to control your MS, then you should continue your current therapy. If you are waiting to start a new therapy, I think this would be best discussed because this would be a personal situation. This would be best discussed between you and your MS care provider. But there would be no blanket statement to discontinue therapy or anything like that at this time. And then the last few things I wanted to comment on is treatment. I know there's a lot of talk about potential treatments, about new treatments, and we're all hoping to have something to offer our patients. Right now, there are no treatments approved for COVID-19, although there are many ongoing trials to look for treatments. So there are many treatments currently being studied, and I'm sure you've read about them in the news. But there's nothing that has been recommended by infectious diseases societies outside of clinical trials. So that sort of brings us to what can we do to prevent ourselves from getting unwell or to prevent this disease from spreading. So a lot of these are things that have been recommended by public health agencies and things that would prevent are good prevention strategies for everybody. So wash your hands often, either using soap and water for at least 20 seconds or using an alcohol-based hand sanitizer. Physical distancing is important. You're looking at about 6 feet to 2 meters if you can. Covering your cough when you do have a cough. Isolating if you are feeling unwell, so not going out. And then, of course, seeking medical attention if you have worsening symptoms. So I'm going to skip this slide because I understand the questions are going to come at the end, but I will just quickly touch on a few questions that we were sent by email. So the first one was about smoking and COVID-19. So does smoking put you at increased risk of COVID-19? And the question was about both cigarettes and marijuana, so I'll just talk about both. So one is touching your face or your lips as you would with a cigarette or with a joint may actually facilitate spread because you are touching your face and touching your mouth. And then if you do have underlying lung disease, as several people who have smoked for many years do, that can actually increase the disease severity of COVID. So both of those things might increase the disease severity and the possibility of increased transmission. Another thing to just be aware of with smoking, we do know that people who smoke are more likely to get other respiratory diseases such as pneumonia or influenza. They would be at higher risk. And so extrapolating from that information, we would conclude that smoking might increase your risk of COVID-19, but of course we don't have direct evidence in this particular disease and this particular virus. This is just kind of information from other respiratory diseases. There was another question about immunizations and COVID. So whether you can get immunized while there's a pandemic going on. This is not about an immunization for COVID. I just want to be clear about that. We don't have a vaccine for this virus. So this would just be your routine immunizations. So you can still get immunized. You can call your closest public health clinic. That's how we do it in Alberta. But if it's not an urgent vaccine or it's not, I know people usually get a lot of vaccinations before biologics start. So if it's not essential that you get the vaccine in the next month, then they might ask you to defer. So just keeping that in mind. And then the last question I wanted to touch on from the emails was about the BCG vaccine and COVID. So BCG is a live bacterial vaccine that's used in countries with high tuberculosis rates to protect against tuberculosis, usually given to children and infants. There's a few what we call preprints. So preprints are not reviewed literature. They're just papers that have been written but have not been reviewed by editors of a journal. And so they are prone to more bias than published literature. Okay, so there are these preprints that suggest that maybe BCG is protective because countries that have BCG vaccination programs have lower mortality than countries that do not have BCG vaccination programs. However, there are many confounding factors with this, because if you're just looking at the vaccination program, you're not looking at the capacity of that country to test for COVID, to do COVID surveillance, to look at their population and the age distribution and the comorbidities, then you're not really getting a full picture. So currently there is no evidence that BCG is protective. And so this is not something that would be recommended or would be thought to be protective if you had it. And I think that was the last slide I had. So I'm going to stop the sharing and I'm going to hand it over.
Thanks very much, Dr. Sonpar. That's really appreciated, and thank you for taking the time to address some of the questions that have been already submitted. It's wonderful, and I'm sure there'll be some more questions. And for the listeners and viewers, we will have some time near the end, of course, for more questions as well. I'm going to move on to our second speaker. Dr. Alikhani is a neurologist with a subspecialty in MS and neuroimmunology. Dr. Alikhani is a clinical assistant professor of neurology at the Department of Clinical Neurosciences, University of Calgary, and director of the Neuroimmunology Clinic in Calgary. Thanks for being with us today, and over to you, Dr. Alikhani.
Thank you, and hello, and bonjour. I'm very happy to be here to talk to you a little bit about what we know so far about COVID-19 and multiple sclerosis. Thank you, Dr. Sonpar, for that fantastic presentation. So I'd like to start off by, first of all, I don't have any disclosures, but a big disclaimer: there are multiple unknowns about SARS-CoV-2. There's a lot that we don't know about COVID-19. Our understanding of COVID-19 and its effects on people who might be at risk is evolving literally daily. And the recommendations that we are making to our patients are really based on what we understand so far from this disease. And it is really evolving as more information becomes available. So I'll start off with guidelines regarding DMTs. I'm not going to go over risk factors and ways to prevent, because they were very nicely already covered by Dr. Sonpar. There are numerous guidelines from a variety of societies. The MS Society of Canada, you will see these guidelines available on the website. The UK MS Society, the Association of British Neurologists, the Australian, the Italian, Belgium, MS Society, the National MS Society, the US, Multiple Sclerosis International Federation, all have similar pages and guidelines and recommendations regarding DMTs for during the COVID-19 pandemic. And the reality is that there are always, disclaimers regarding these being based on expert opinion, as well as the fact that they will be evolving based on our evolving understanding of this disease. The principles are always similar, and as Dr. Sonpar mentioned, first of all, there is no recommendation for people to generally stop their disease-modifying therapy. And of course, it's really always recommended to follow the advice, the guidance of the public health authorities in Canada and in your jurisdiction in your province, and that also is updated and it changes. So that is also an evolving. It has been, as you would know, an evolving recommendation. With respect to specific disease-modifying therapies, there are general principles that are shared across the board that would include some caution about starting treatments that are considered to be cell-depleting. That would include alemtuzumab, cladribine, ocrelizumab, and rituximab. That is basically an off-label therapy for MS. and also some concerns about stopping certain medications that are associated, stopping these medications could be potentially associated with a rebound disease activity. And these would include specifically fingolimod and natalizumab. So with that, there are also specific recommendations from the Canadian Network of MS Clinics, a group of MS healthcare providers and neurologists who came up with a consensus recommendation and actually a Q&A statement that is available on this website as well, the Canadian Network of MS Clinics. That also needs to be really, it is updated, it needs to be updated, and the general recommendation, of course, is that the decision about MS therapy should be really made in discussion with your MS care provider. And it is really, again, based on expert opinion. We don't have any specific research to guide MS management with respect to COVID-19. And it's also based on, it's based on the information that we have so far, the experience from other similar infections and epidemics, as Dr. Sonpar mentioned, and some known mechanisms of actions of these medications. So the first important question that was also shared, with a lot of, coming from our registrants, is whether MS per se is a risk factor for getting COVID-19, and the answer is generally no. Having MS per se does not put somebody at an increased risk of getting COVID-19 or having a more severe course. We don't really have any information to support that. However, we do know that there are a lot of caveats that are important. For example, if there are certain comorbidities such as increased age or cardiovascular risk factors, those could potentially cause some, increase the risk of COVID-19. What is the impact of getting COVID-19 specifically for a person who has MS? That is an important issue. It was a question that was also asked by our registrants. Yes, it could have potentially an impact. We know that in MS, maybe about a third of MS relapses are associated with a prior infection, most often viral. So that is very important, needs to be kept in mind. The other issue is that, with an infection, there is a risk of a pseudo relapse or a pseudo exacerbation as well. There are specific issues in this regard with for people who have primary progressive MS, since in primary progressive MS, we know that there could be infection-associated exacerbations as well that don't fit the definition of a relapse, but they also impact, the patient's well-being. So these are all important factors. So it's very, very important to make every effort and take extra precautions to avoid an infection for those reasons. And then, of course, if a person with MS has a severe physical disability, for example, causing weakness in the muscles that are involved in breathing, or difficulties with swallowing, that could also cause some issues that would lead to a more perhaps severe course of COVID-19. And then finally, there are certain disease-modifying therapies that might, and that's really, and I want to emphasize that we don't know for sure, but that they might actually place someone at an increased risk of getting COVID-19 or having a more severe course. So the other question that is asked very often is, should I stop my disease-modifying therapy? And then again, the general answer to that is no. Again, remember, this is something that needs to be discussed with your MS care provider, but that is the general answer. first of all, stopping disease-modifying therapy could potentially lead to a relapse. Having a relapse, sometimes that might require treatment with steroids. That itself is going to be problematic during a pandemic. In general, we don't recommend treating all relapses with steroids. We would recommend that even less often now during the pandemic. But as you know, there are situations where treatment with steroids are recommended. So basically, bottom line, we don't generally recommend stopping your DMT unless there is a very good reason to, and in discussion with your healthcare provider. So for some medications, such as beta interferons, glutamate acetate, teriflunomide, and minocycline, we don't really think that they have any major immune suppressive effects. For mildly immune suppressive medications, for example, natalizumab and fingolimod, and sometimes if difmethyl fumarate is associated with low lymphocyte counts as well, we don't generally recommend stopping the medication. With that in mind, we have to again remind ourselves that fingolimod and natalizumab can be associated with possible, stopping these medications can be associated with a possible rebound MS activity. Interestingly, fingolimod or Gilenya is being studied as a possible treatment. So it is actually a medication that is being studied in a clinical trial for a possible treatment for COVID-19. Again, going back to Dr.'s point that being immune suppressed is not automatically leading to a conclusion that there will be a worse outcome with the COVID-19, because as we know, some of the very severe manifestations and presentations of COVID-19 are not related to the infection itself, but related to the immune system basically becoming overexcited as a result of the infection. So it is, again, stressed to contact your healthcare provider if you are having symptoms of COVID-19 or if you have tested positive. This is very important because on a case-by-case situation, there might be decisions to delay treatments, to change the dosage of medications, to suspend treatments, and this is, again, a very case-by-case decision. And second, it's really important to know, for example, if somebody is having symptoms, they need to be self-isolating, there will be an inevitable delay in getting their infusion if this is being done at an infusion center. So many different caveats to that. So please do call your MS care provider if you are having symptoms of COVID-19 or if you have tested positive. There was a question from the group about whether there are any studies, what is being done with respect to collecting information. So this is another reason why it's important to call. There is a registry that started in Europe and in Italy and then Spain, involving the UK, and it will also eventually be involving North America, the US, and Canada. And it's called COVID-MS, which is basically a registry of people with MS who have been affected by COVID-19. And this will allow us to know what are the numbers, what is the course, what has been the outcome. So far, what we know, we don't really have published information, but we do have webinars and weekly updates from especially our European colleagues, where COVID-19 has been were more prevalent, and our colleagues are the MS neurologists in Europe, especially in Italy and Spain. They are reporting some cases that they have seen, but honestly, and this is really unpublished information, it is really too soon for us to reach any conclusions whatsoever. However, in their opinion, so far, they are not seeing a specific signal for an increased risk based on their experience. For people with MS or people who are on specific medications. The cases that they they are unofficially reporting in these weekly webinars are mainly patients who have other comorbidities, either older or who have cardiovascular risk factors. Again, this is all very preliminary data. This is unpublished. This is based on cases that are being reported on a day-to-day basis. So the other question that we're getting a lot, and it was also coming from our registrants, was related to a specific treatment, really ocrelizumab or rituximab. The reason why ocrelizumab and rituximab are being lumped together is because they're very similar in the way they work. They target a specific type of white blood cell, specific type of lymphocyte. It's mainly B lymphocytes that are targeted with this treatment. It's from past experience, people who are treated with these medications do not have a very significant increase in the risk of getting viral infections. So we don't really anticipate that there would be, this would be considered a contraindication for treatment during the pandemic. However, if you have COVID-19 or you have had a close contact who has had it, then the situation is different, and it's going to be a discussion. It will be I would suggest that it would be delayed in that case, but it is again a discussion that has to be had with your healthcare provider. A lot of MS care providers, neurologists are recommending delays during the pandemic if for a variety of reasons. The reality is that delaying ocrelizumab is not associated with rebound disease activity. So remember, rebound disease activity is when you have disease activity that's kind of above and beyond what you had prior to starting a treatment. So we're not really seeing that with the delaying ocrelizumab. We're not, and we also know that the treatment effect for ocrelizumab, it persists more than 6 months. So even though the treatment is scheduled as every 6-month infusions, the effect of the treatment typically lasts longer. So delaying a treatment by 2 to 3 months usually does not have a huge impact on MS activity, and it is not associated with rebound disease activity. I discussed this with your MS neurologist, and I don't, and the general agreement and consensus based on current information is that we are not too worried about delaying this treatment by a few months. And that is shared across the board in Canada and also in other countries. Okay. I have been on cladribine or Mavenclad or alemtuzumab or Lemtrada recently. Am I immune compromised and likely to have severe disease with COVID-19? So this is a great question. It is very, it's a very important question as well. Again, we don't have information. However, these treatments are both considered very high efficacy treatments that target lymphocytes. They're called cell depleting agents, meaning that they pretty much wipe out some of the white blood cells. And there's really nothing that you can do to reverse that effect. It takes time for that effect to be reversed. So, and yes, they are associated with an increased risk of certain types of viral infections. Depending on how recently you completed your treatment and what your lymphocyte count is, you will be considered immune compromised, and there are extra precautions that need to be taken. Is it possible that you would be at an increased risk of COVID-19 or a more severe disease? Again, we don't know, but it's not an unlikely situation where there would be an increased risk of getting COVID-19. If you have been recently treated with these medications, and if your lymphocyte count is less than 0.5. And again, remember, this is based on expert opinion and the consensus of MS neurologists across Canada. But this is also shared, this opinion is also shared with, other MS neurologists in other countries as well. So for example, the UK, and I am not saying that we should necessarily do that. Again, remember, discuss this with your MS care provider. But the UK, they are in fact suggesting isolation for 12 weeks after completing the course of treatment with cladribine and alemtuzumab. So it is something to keep in mind, and discuss this with your care provider as well. Another point that I'd like to make with alemtuzumab Lemtrada specifically is, there is a requirement to do monthly blood work with this treatment. Some people would ask, okay, I really don't want to go to a lab. This and a lot of labs are actually not doing, and as I know in Alberta, at least, they are not doing regular or routine lab tests. It's not business as usual in any lab. However, if you have been on alemtuzumab, it is very important that you continue and basically adhere to the recommended monitoring measures, because one of the purposes of this monitoring measure is really to know if you are at an increased risk of certain complications and side effects, including infection. So yeah, we still have to continue with that monitoring. Call your lab. Make sure, however, that I would suggest that people would call their labs and make sure that they are following the appropriate process that has been advised during the pandemic. The other question was, I'm about to start on a therapy. Should I delay starting? And the short answer to that is maybe yes, maybe yes. Not all therapies need to be delayed. There are treatments that are not associated with immune suppression, and there's really no need to delay starting them unless there's a specific situation. Some people are considering a delay because of the requirement to do closer monitoring blood work initially when you start a treatment, and that's a valid reason, but again, it has to be assessed on a case-by-case basis. Across the board, if you are starting a cell-depleting therapy such as alemtuzumab, ocrelizumab, rituximab, or cladribine, more often than not, there is a recommendation to delay starting treatment, especially for cladribine, which is Mavenclad, and alemtuzumab, which is Lemtrada. Less so for cladribine than alemtuzumab, actually. If all of this needs to be weighed against the need for starting therapy based on disease activity. So I can tell you, for example, from my own personal practice and experience, on the same day that I have advised a patient to delay therapy, I have advised another patient to start as soon as possible. So it is really a decision that needs to be made on a case-by-case basis, weighing the risk of the treatment against the therapy, risk against the benefit, sorry. Okay. And so yes, finally, this is slide just summarizing the different recommendations for particular treatments. For glatiramer acetate, which is Copaxone or Glatek, no need to stop. Even with COVID infection, we don't really think that there should be a suggestion to stop treatment. Interferon beta, which would include Avonex, Betaseron, Rebif, Plegridy, or Xtavia, no need to stop treatment. Teriflunomide or Aubagio, no need to stop. Most of our colleagues would not even suggest stopping with the COVID infection. The recommendation of your MS care provider could be different. Minocycline is sometimes used in Canada as off-label therapy for MS. That also needs to be discussed on a case-by-case, but we generally don't recommend stopping it. Dimethyl fumarate or Tecfidera, if the lymphocyte counts are below 0.5, there might be a need to hold the medication until they bump back up again above 0.7. Again, this is not a general consensus statement across different jurisdictions, but this has been the consensus of the, as I said, the Canadian Network of MS Clinic. All these recommendations are subject to change, so please discuss with your MS care provider. Natalizumab or Tysabri is interesting because initially our recommendation was that we don't really need to change our practice. In fact, a lot of people who have highly active MS were suggested to consider this during the pandemic because of its very specific mode of action. However, more recent studies showed some cases that were thought to have COVID, the virus, the SARS-CoV-2 virus in the brain, suggesting that with the very severe infections, the brain can be affected as well. And based on that preliminary information, we are basically, for myself at least, reconsidering that recommendation that it can be continued even with COVID. The reality is that these are every 4 weeks infusions. The infusions can be delayed safely. In fact, we have protocols that involve extended dosing that has been done safely with every 6 weeks to 8 weeks infusions. So this is again a decision to be made on a case-by-case basis, but we are not generally recommending that people stop their natalizumab or Tysabri during the pandemic. First of all, it can be associated with rebound disease activity, and secondly, we don't really have any evidence that we need to be doing that. There are, again, special situations where it needs to be done, depending on whether you have symptoms or the actual infection or the availability of infusion centers. Gilenya as well, with fingolimod, no need to stop, but and remember that if you do stop, if you have COVID-19 or if you have symptoms, then there is a risk of rebound disease activity, but the risk is not very high during the first few weeks. But if you are off therapy for fingolimod for a while, then restarting it would require, again, first dose monitoring, depending on the length of the interruption. So for cladribine, again, extra precautions, especially if lymphocyte counts are below 0.5. We do consider delaying start of treatment with this medication, as well as with Lemtrada alemtuzumab. With ocrelizumab rituximab, we already discussed that. With hematopoietic stem cell transplantation, which is not included here, it is universally recommended to be delayed for the time being. And this is a final slide that I just include because I just want to point out that this is the version 3 of these recommendations that are made by one of the very active MS clinics in London, England, where I just want to point out how fluid the situation is and how things are changing based on information. The change that was made in the version 3 of this table was that Tysabri was removed from low risk to intermediate risk for every 4 weeks infusions and low risk for extended dosing infusions. So thank you very much, and I'm happy to take some questions.
Wonderful. Thanks very much, Dr. Alikhani. I really appreciate it. Now we do have some time for questions, and I would like to thank everyone for submitting their questions through the chat box. I've been watching them as they come through, and many of them came through regarding DMTs, but Dr. Alikhani, your last few slides, I think, answered quite a few of those questions that they had. However, there are a few outliers that I'd like to pose to you at the moment. And as a reminder to our listeners, if we don't get to all of the questions, please accept our apologies, but we will put out information as we go along, and we can carry some of these pieces forward to future webinars as well. But Dr. Alikhani, a question for you. Can you comment on siponimod? I know there's a question around whether or not someone should wait to start to take this particular medication.
Again, it's a very case-by-case situation. It really depends on the degree of disease activity and other risk factors and comorbidities. So I would, again, suggest discussing this with your MS care provider. I don't really see this to be as a general contraindication, so I wouldn't really place it where I would place alemtuzumab or hematopoietic stem cell transplantation. So it's not a big general no, but it is there might be situations where a delay would be warranted.
Thank you. Thank you. Dr. Sonpar, there were a group of questions around isolation, as if you're living with MS, and your partner or caregiver or someone's working, still has to work, provides essential services, etc. Like, should you isolate from your family? So could you comment on how far or the extent of that people need to take regarding isolation, in particular as relates to the family dynamic?
Sure. So I think in general, following those physical distancing measures for anyone who is not part of your immediate family is very important. Of course, you can't completely isolate yourself from everybody. And so at this point, we're not recommending physically distancing yourself from your immediate family. What I would suggest is, obviously, if you have a partner or a family member who works for essential services and they work in the hospital or in the clinic, when I come home, I wash my hands and change my clothes. And I think a lot of essential workers are being told that that's what they should do, and maybe in an attempt to protect their families. So those are the types of things. And of course, if you have family members or other persons in your immediate family, having them go grocery shopping instead of yourself is another thing that you can do to maybe reduce your exposure and protect yourself. And if anyone else here has any other thoughts, I'd be happy to hear those as well. But those are the things that I've been doing and that Alberta Health Services has recommended to us.
Thank you. Dr. Alikhani, any comment on that?
No, I would agree. And advised to work from home if at all possible. So I think following the recommendations of the public health authorities is really important in this situation.
Thank you. Perhaps a question to both of you. I know there was a comment around the registry and the data collection pieces that are just starting around the globe. Is there any data currently available that would indicate how many people with MS may have COVID-19? Is that possible to tell at this time? I had 3 or 4 questions from the group on that.
So I can answer that. We don't have anything published yet. This is really fluid and developing, so I don't really have any final answers. It is like a few cases per country that are being reported, cases that are being reported on a daily basis. I don't have concrete data to provide, and I would say that nobody does have that concrete data at this point in time, but I'm sure that we will once these registries have developed and they are published.
Great, thank you. There were a couple of questions around blood work. Now, I know, Dr. Alikhani, you did mention generally, considerations. Is there anything else to point out around people today who are, feeling the need to get blood work done? Is there anything they can do?
Again, it's a case-by-case situation. We have, for example, for certain therapies, delaying blood work if somebody has been on a treatment for years with stability, delaying blood work might even be recommended because that would perhaps prevent unnecessary exposures. It would prevent leaving home for no strong reason. But certain treatments, it's different. I pointed out one of the therapies that absolutely does require monthly blood work, and that is alemtuzumab. I think that, again, it's really important to discuss that with your MS care provider. It is not there's no blanket statement saying that everybody should be getting blood work without any delay. In fact, that would be false, and there are situations where we are making modifications to the frequency of the blood work that needs to be done. The one exception that I would like to point out is alemtuzumab, that is really required. Yeah.
Gotcha. Thank you. I'm noticing the time. I also observed that we did start a few minutes after the hour. I'm going to ask two more questions and then share some closing information. Again, thank you to everyone for being part of today's webinar, and we are recording these questions, and we'll do our best to make sure we get answers out there. The first question I would have, remaining question I have, would be, a couple of people have asked around lymphocytes and the significance between a 0.5 or a less than 1. Like, is there a nuance there? Is there something to be considered or articulated there related to lymphocytes and the difference between 0.5 and 1?
So currently, I mean, it's a great question. And I'm gonna tell you that we don't, what the current recommendation regarding the significance of this 0.5 and below is, it's really based on expert opinion. We do not really have strong data to go by. Recently, some of our colleagues are reevaluating this cutoff and saying that, for example, for the case of cladribine, we should be even more cautious and consider values below 0.7 to be considered low. It is really based on going back to information from clinical trials and the risk of infections that had occurred in people who were participating in the studies of these medications with various values of lymphocyte counts. So this is where this 0.5 is really coming from. And I would say that, for the time being, we are all adhering to that. But as I said, for example, for the case of Tecfidera, the thought is that, if the lymphocyte count is below 0.5, we would suggest maybe holding the medication until it bounces back up to 0.7 or higher. So that's really it's a consensus, not based on concrete data during the pandemic, but based on information from previous, clinical trials and studies and infections in those studies. I hope that answers the question.
Thank you. Last question before I close, and there was commentary on comorbidities and a number of specific questions, but in particular, is there information to be shared around asthma or sleep apnea and its impact or implications related to COVID and MS?
I haven't seen any data on sleep apnea in particular, but of course, anyone with underlying lung disease could be at risk for complications given they already may have some abnormal lung function. And of course, COVID-19 does affect the lungs. And so we are seeing people who have asthma or COPD or other underlying lung diseases may have higher risk of complications.
Okay, thank you. And again, thanks so much to Dr. Sonpar and Alikhani. I appreciate your time and your information and the level of preparedness that you brought today. It's really appreciated. In closing, I just want to make sure I get the screen up here for everybody here. As we close off, I certainly want to remind you about the MS Society of Canada's Knowledge Network, which is staffed by trained navigators to answer questions related to MS, including MS and COVID-19. They provide consistent, quality information and support, and you can see on the slide before you how to connect with them through phone, email, or live chat. The next webinar in this series is tomorrow, featuring 2 MS nurses. This webinar will be in French with simultaneous English translation. The third webinar is next Wednesday, April 22nd, featuring a psychiatrist, a physiatrist, and an MS nurse. It will be in English with simultaneous French translation. Please remember to register for each one individually in the language of your choice to get the correct link. Finally, as you may know, or of course can imagine, the MS Society of Canada has had to shift how we are connecting our MS community, and of course, connecting is now more important than ever. I encourage you all to visit wechallengems.ca, www.wechallengems.ca, to learn about a new nationwide movement to virtually challenge MS together as we approach MS Awareness Month in May. Again, thank you for participating in today's webinar. Thanks to everyone who made it possible, and I wish you all a wonderful day. Thank you.